A very warm welcome from FLCCC. This is Dr. Mobeen Syed. Today we are going to look at a study which discusses and characterizes the long COVID symptoms in international cohorts, 7 months of symptoms and their impact. This study is done by the researchers in UK, US, and US. And this was a voluntary study. This is not a funded study by any of the organizations. And this is a beautiful set of data points to understand. Now, what is the reason for discussing this study for us? Last week, we discussed the prevalence of the long COVID symptoms. That is what percentage of the society has long COVID and the most common symptoms. And as a quick refresher, 2.7% of the UK population, that data was from UK, 2.7% of the UK population has long COVID. Some of them, about 4% of them, from 2 years. And about 8 to 9% of the COVID cases have long COVID. So that's a very high number, and you can extrapolate that with some confidence for other countries as well. Of course, every society and their socioeconomic system and their culture habits are different, so long COVID's prevalence may be different, but you could come very close to at least estimating the number of people suffering in a specific country or geography and what kind of suffering they may have and for how long. So today's study would actually build on that. In this study, what we will discuss is, number one, what are the kind of neurological symptoms and non-neurological symptoms that people are suffering with. Second, how many organ systems in our body are involved in it. Thirdly, how long these symptoms continue to be present in long COVID patients. So let's start our discussion. Quick references. This is the study itself. Then here is the PDF. I'll use parts of the PDF to discuss some of the symptoms. This is the UK's data from their Office of National Statistics. And I discussed this data last time. Only reference here is the 2.7% of the population. This is the list of organ systems in our body, major organ systems, about 11. And you would see that the organ systems that are involved in long COVID are on average 9.1. So almost all organs are involved in long COVID. This is such a devastating outcome. Then this is another study which I would just go over very quickly in the beginning to set the stage. This study says, this is a preprint, and they're talking about multiple organ impairment in long COVID. 1 year prospective longitudinal cohort study. And finally, here is another article which is really interesting, and that is about the cognitive decline or neurological outcomes for the long COVID. We will continue to see these studies in our future times as well. Today, I wanted to set the stage to understand the symptoms, the chronicity of the symptoms, and then we would start talking about pathophysiology and management approaches in the future lectures. So let's start from here. This study, preprint, but it has a very interesting set of messages here. Number one, extreme breathlessness, 36% and 30%, cognitive dysfunction, 50% and 38%, and poor health quality of life were common at 6 and 12 months. So these two numbers, 36% and 30, so 36% at 6 months and 30% at 12 months. And you would continue to see that this trend of, fortunately, long COVID gradually reducing in symptoms in people over time. But that time is very long. It can be more than years, 2 years at least as well. So similarly, cognitive dysfunction, 50% at 6 months and 38% at 12 months. There was fibroinflammation in the heart, 9%, pancreas, 9%, kidney, 15%, and liver, 11%. Increased volume in liver, 7%, spleen, 8%, kidney, 9%, decreased capacity in lungs, 2%, and excessive fat deposition in the liver, 25%, and pancreas, 15%. The point of presenting this is to set the stage that almost every organ system is involved, and the long COVID is a chronic disease. If not managed, it can continue on for months and years. Now let's go to my preparation for this study. So once again, characterizing long COVID in an international cohort. This is that study. A quick summary of the study. More than 91% of the patients had more than 35 weeks to recover. So more than 7 months, and more than 91% of the patients. That's how bad it is. There is a good news in here, and that is that even without intervention, patients continue to feel better. However, this is not always the case. I have seen patients, and I know patients who have only become worse over time and are not recovering. So please don't take this message as all the patients in all the cases will automatically become okay after some time. I wish that everybody does, but it is not the case. Then they say, this study, participants experienced an average of 55.9 plus minus 25.5. So anywhere from 25 symptoms in one person on average to 75 symptoms in a person, involving an average of 9.1 organ systems. So out of 11 major organ systems, 9 are mostly involved. That's, again, as I said before, it is devastating. The top 3 most debilitating symptoms, and this set of the top 3, fatigue, breathlessness, cognitive dysfunction, you would see that this set of diseases is very common in long COVID despite the variant. What I'm seeing is, so I'm speaking outside of this study now, what I'm seeing is that with Omicron, chronic cough, tinnitus, and cognitive issues is most common. But generally from data, fatigue, breathing issues or respiratory systems involvement, and cognitive dysfunction are the 3 most common. And they are, all 3 of them are devastating, disabling. And 85.9% of the participants experienced relapses. 85.9% had relapses. And this is the biggest problem you would see in the chronic COVID or long COVID patients, that they feel great for a week, 2 weeks, and then they do something, they have something, they become tired, or they are stressed out, or they go have fun and play, and all of a sudden they have a relapse. So almost 86% have a relapse. And how does a relapse happen? Exercise, physical and mental activity, and stress. 45.2% required a reduced work schedule. Check this out, this number, almost half of the long COVID patient, they needed to reduce their activity because of the disabling outcome of the symptoms or the illness. And an additional, this is not out of these 45.2, an additional 22.3% were not working because of the illness at the time of the survey. And survey followed folks or analyzed folks for about 7 months of their history. Can you imagine 22.3% not working at all because they are so disabled? And I have seen patients, very young patients, 22 years old, 23 years old, bedridden, not able to do their work. And on top of this, their doctors, their family members are saying, this is all just in your head. You are making it up, or try to improve, go for a psychotherapy and so on. Although you would see that with the long COVID, these neurological and psychiatric problems are also present. But think about it, that on top of that, patients are told that, hey, this is just all in your head, you're making it up. Now the characteristics of this study. So we have done the summary. Now I'm going to go to the properties of this study, and then we'll go deeper in the symptoms in various organ systems. So this study, this was an online survey. It was done September 6, 2020. So note the time, 2020. So it is not Omicron time, it is before, to November 25, 2020. Although, as I discussed the long COVID symptoms and prevalence last week, you would see that symptoms are very similar. There is a deeper and more expansive look at those symptoms in this study. So the survey was created by a team of patients with COVID-19, and the researchers who were involved, they were from Oxford, UK, from Weill Cornell University, New York, and from Oregon University. So what is the intent of the study? What were they trying to do? The survey was created to investigate details of recovery, testing results, the impact on mental health, and a more comprehensive set of symptoms, with greater emphasis on neurological symptoms. So again, for all of our discussions in the future, this study is going to set the stage for us to understand what are the symptoms and what are the most common symptoms and how long do they stay. So the study itself was approved by the University College London Research Ethics Committee, Oregon Health and Science University Institutional Review Board, and the Weill Cornell Medical College IRB determined non-engagement. They had 257 questions. These questions were created in English and then translated in 8 more languages. Because of that, they actually had the participants from 52 countries. So it is an international cohort, which also tells you that these symptoms are actually very common and very prevalent and very similar across the world. So if you take the world population and then take 2.7% of that, or you take all the cases in the world and you take 8 to 10% of that, that is the number of people who are suffering right now. And some of them disabled to not even be able to work. This is how serious this problem is. The inclusion criteria was patients have had a COVID-19 or suspected COVID-19 infection test result or symptoms for longer than 1 week, and the patient had to be 18 years or older. The survey had 203 symptoms and 10 organ systems. Illness lasting for more than 28 days and started before June 2020. That was the criteria. Now they had a total of 3,762 patients, 52 countries, 1,000 confirmed COVID positive, and 2,742 suspected COVID positive. Females were 78.9%. And you would see that actually more females are becoming victim of long COVID compared to men. And one of the reasons is that immune system is a little more active and aggressive in women. And when we talk about autoimmune diseases or inflammatory conditions, they become more prevalent in women. This study primarily was leaning towards whites, so 85.3%. Because of that, we cannot really very confidently map it to non-white communities. The ages were between 30 and 60. So 33.7% were 40 to 49, 27% 50 to 59, and 26% 30 to 39. So out of these patients, more than half of the respondents did not seek hospital care. So about half of them had the symptoms, but they didn't go to hospital. 34.9% visited an ER or urgent care clinic, but were not admitted to a hospital. 8.43 of respondents were hospitalized, 17.8% were healthcare workers. Now, what are the findings? I've given you the summary before, so I'm going to go deeper in the findings. And again, if you're a healthcare worker, healthcare professionals, or healthcare student, it is really important to understand these symptom sets, because we would then talk about the pathophysiologies and management. So, and this is also important to understand how long the symptoms stay. So 91% or more than 91% continue to have the symptoms beyond 35 weeks. And then, as I said before, symptoms were anywhere from 25 symptoms in one person to 75 symptoms in one person. So 55.9% plus minus 25. Organ system 9.1. Most common, once again, fatigue, post-exertional malaise, and cognitive dysfunction. Post-exertional malaise is you do some work and afterwards you kind of feel down and out and depressed, unhappy. This is actually not something in your head. Of course, it is psychological and psychiatric. It is not in your head in a way that you're making it up. It is actually a response to the neuroinflammation or nervous system tissues involvement. 85.9% of the participant experienced relapses, and the relapse was exercise, physical or mental activity, and stress. 86.7% of unrecovered respondents were experiencing fatigue. 86.7% or 87% patients had fatigue, compared to 44.7% who had recovered and they also had fatigue. 45.2% required a reduced work schedule, and 22.3% additional percent had to stop work. They were disabled. About 88% had cognitive dysfunction or memory issues. This is huge. And we had done a discussion about long COVID at a different time. And over there as well, this was the most common complaint, that because of cognitive and memory issues, it bothers me a lot. Plus, I cannot do my day-to-day activities. And this was across all age groups, from 30 to 60. This was not that, hey, this is a problem with the advanced age. All age groups were experiencing it. Now, let's have a deeper look. First of all, this graph from this PDF that I have shared the link with. This graph, what it shows is, if you see here, probability of continuing to have the symptoms. And on the x-axis is the weeks of illness or time. So if you see here, 35 weeks later, the probability of symptoms was 0.93 as well. So it was very high in the early weeks. This is the week 5, for example, but it reduced over time. But if you see here, it did not reduce down to 0 or go away. There was actually still 0.94 probability. And if you see here, the blue line is those who were COVID negative. Positive is the orange line, and then all. And interestingly, so the COVID negative are those who were negative they didn't have the test, or the test was negative, but they had the symptoms and it was suspected they had COVID. If you see here, in the middle of this symptom set, or the tracking of the symptoms, there was a difference between the positive and negative. But near the end of 35 weeks, they all became almost the same. So what is the takeaway of this? The takeaway is, even after 35 weeks, even after 7 months or so, there is a high probability that patients would continue to have the symptoms. Then average number of symptoms over time. So the y-axis, average number of symptoms, and the x-axis, once again, time. So if you see here, the not recovered in lesser than 90 days. So if there are patients who have not recovered in lesser than 90 days, that is, their symptoms continued after 3 months, they continue to then have it even after month 7. Those who recovered within 3 months, if you see here, by 6.5 months, their symptom sets went down to almost 0 as well. If they had started recovering within 3 months, then their chances of being symptom-free within 6.5 months were very good. Then if you look here, this is the triggers for relapse. What were the reasons for the relapse? So if you see here, stress and exercise and physical activity were very important triggers. In addition to them, alcohol, caffeine, heat, mental activity, menstruation, week before menstruation, and others. These caused relapses. And finally, I'm going to now go to the PDF itself and show you a couple of symptom clusters for non-neurological issues and neurological issues. So let's look at them. This is actually the most important part of the talk and the last part as well. So here, this is the non-neurological symptoms. And as you can see, this is a very rich set of data. Here, the top diagram, the diagram number A, is an accumulated summary of all the other organ systems here. So fatigue, for example, was the most common. Post-exertional malaise was second most common. Elevated temperature or fever, third most common. Then chills, skin sensations, paresthesias on the skin, the pins and needle, the burning sensations. Weakness, fatigue, temperature lability, don't like the temperature, warm temperature, night sweats, coldness, fever greater than 100.4 Fahrenheit, heat intolerance, low temperature, other temperature problems. And just to give you an idea, I don't want to read them all, you can look at them, but I'm going to just read a couple of top ones in various systems. For example, reproductive and genitourinary system, extreme thirst, menstrual period issues, menstruations, abnormal irregular period, abnormal heavy periods, and so on. If you see here, head and eye and ENT, sore throat, the most common, blurred vision, vision symptoms, lump in throat, sensitivity to light, and so on. On the vision side, it is actually very interesting that the patients actually don't come in and say, I have a visual problem. What they are experiencing is something like, this is how they mention it. They say, I cannot process the detail. I cannot look at my computer screen. If I go to a grocery stores, I cannot understand all the items that are there and their prices, and I cannot process it. They say things are fast, and they say that I deliberately try to do things slowly because things are fast. This is how they express it. Cardiovascular system, the blue one here, this C, palpitations, tachycardia, pain, burning in chest, inflamed, bulging veins, bradycardia, that is slow heart rate, tachycardia is higher heart rate, and fainting. Musculoskeletal system, tightness of chest, muscle aches, joint pain, stiff neck, muscle spasms, bone ache or burning. And then immunologic and autoimmune, heightened reaction to old allergies. I am seeing this a lot, that patients say that, hey, I used to have this allergies and now they are more. Or I had an accident and I had some muscular and joint pains 2 years ago and now they are flared up again. So existing inflammatory or immune issues get flared up once more. New allergies, and that is what we talk about, unmasking of the allergies. New anaphylactic reactions, shingles, and of course the viral reactivations. Pulmonary system, shortness of breath, this is the G. Shortness of breath, dry cough, breathing difficulty, cough with mucus production, sneezing, rattling of breath, and so on. Then GIT, diarrhea, loss of appetite, nausea, abdominal pain. This is actually very common. Gas, constipation, diarrhea. This is why many of these patients are actually being diagnosed as IBD. And it's actually, if you look at it from long COVID perspective and you manage it from that point of view, I have seen better outcomes than trying to treat these patients as the GIT immune issues. Nausea, abdominal pain. Abdominal pain is very common. Explosive diarrhea is very common. Gas is very common. This is so debilitating that patient cannot actually go out or be in the social settings because they need to go to the restroom very commonly. Constipation, hyperactive bowel sensation, vomiting, feeling full quickly when eating. And then dermatologic, itchy skin, skin rashes, petechiae, small tiny dots like pin needle head, like red dots. COVID toe, peeling skin, skin allergies, brittle and discolored nails, dermatography, itchy, and other. And I have also heard burning sensation under the skin and pins and needle very commonly. Painful toes, COVID toes. These are non-neurological symptom sets. Now let's look at the neurological symptom sets. So these are neuropsychiatric symptoms. And again, I'm not going to read them all, but some. Emotion and mood. Anxiety, irritability, depression, mood lability. Now the question is it in people's head? They're just making it up? No. When there is an inflammatory state of the brain tissue, the brain's function is personality, mood, decision making, doing day-to-day activities. So those functions are disrupted or changed, which will cause mood change as well. This is one part of the brain's function, to have a mood or our emotions. So they will become imbalanced. Personality areas, when they are affected, the personality would change. Motor areas, when they are affected, the motor activity and coordinations will change. Sensory areas, when they are affected, then the sensation itself would change. Olfaction changes. The people sometimes say that, hey, I smell smells which are not in the environment. Right? So these are actually problems because of the involvement of the nervous system tissue, and not because people are just making it up because they're depressed. Sensory motor. So B. Sensory motor is sensory system, our feeling system from the touch and pressure and pain and temperature. And motor is the activities that we do voluntarily. So dizziness, vertigo, balance issues, tingling, pins and needles. This is very common. Tremors. This is also very common. People would say that my body is buzzing and it is trembling. Numbness, loss of sensation, sensitivity to noise, and so on. Tinnitus is very, very common nowadays, even more common with Omicron. Sleep. Insomnia is very common. Inability to sleep correctly. Waking up several times at night. Interrupted sleep is very common. Difficulty falling asleep. Awakened by feeling inability to breathe. Cognitive functions. Brain fog. This is a very common symptom that people present with. Brain fog. And what do we mean by brain fog? The confusion, the state of confusion. Lack of clarity. They go to the grocery store and they cannot correctly process what are the things on the shelf, what are their prices, what is it that I'm looking for, what is it that I'm going to buy. They stand with their friends and they are confused with the overall environment. So there is a state of confusion and lack of clarity, which is then called as brain fog. Poor attention, difficulty in thinking, difficulty executive functioning. So executive function is, for example, I'm sitting right here, I'm doing this lecture, and so there are certain personality traits I have. How am I speaking? What am I saying? How is my hand gestures, and so on. So these decision makings that make us human and unique, all of us, these are our executive functions. And that set of executive functions or those decision making or personality can become altered. A person may start becoming a very different person from where they were before. Difficulty problem solving, slowed thoughts, and so on. Memory, huge problem. Short-term memory loss, long-term memory loss, other memory symptoms. This is a very common thing even now in youngsters because of COVID. Once again, we are fortunate that these symptoms start reducing over time. But it still takes months and years. And in some, it does not reduce. Headaches. Headache behind the eyes. Headache diffused, headache in the temples, and so on, base of the skull. Taste and smell. So this is very, very common. Loss of smell, loss of taste. Now the loss of taste is really because of the loss of smell. So we have, the taste is flavor, which is a combination of the taste sensation coming from our tongue and the mouth areas, and then the mixing of that with smell to create flavor. So when the smell part of flavor is gone, then the taste is just like you cannot differentiate now between an apple and a potato, because the smell was, or the fragrance of those products would have told you it is an apple or a potato, and now you cannot. So many patients would actually say that everything I eat feels like mush. because their olfaction is not contributing to understanding what they're eating. And so they cannot tell what they're eating. So it becomes bland and boring, and it becomes irritating for many. So that is the lack of olfaction. And we did this study a few days ago that the lack of olfaction, or the problem with the smell, then in turn causes the shrinkage of the brain areas that are connected with the olfactory system. And almost all the brain areas are connected with the olfactory system, because olfaction, or the sense of smell, is an important driver for our behaviors. That is the animal in us works with smell. And so it is connected to our memory system, it is connected to our personality system, it is connected to our whole ear and eyes system. You can look at some food and you can start feeling hungry or not. You can start feeling the smell of it just by looking at it, or you can hear the foods cooking or the frying, and you can have the whole emotion set up. So sense of smell is actually connected almost to every part of the brain. And so when that sense of smell is not working, then the disuse, atrophy starts occurring in the whole brain. And this is what the Oxford study showed, that the global brain size reduces after the sense of smell has become interrupted or become abnormal. Phantom smells are very common. People say, I smell coffee, or I smell something burning, and there is nothing like that. They would actually go down or go to their kitchens or other places in the home to see, is there something burning? Speech and language, difficulty finding the right words. And you would see that many of these are actually signs of dementia as well. So the question is, are these folks going to have early start of dementia, or this is going to be temporary? This is why I believe, just like with COVID, that early aggressive treatment is important. Similarly, for long COVID, early aggressive treatment is also important. So speech and language, difficulty finding the right words, difficulty communicating verbally, changes to non-primary language, and so on. There is one more thing I wanted to say, that the prophylaxis for long COVID starts within the acute COVID time. So what medicines are being used at that time would also determine if the patient becomes long COVID, or what is the intensity of long COVID. Hallucinations, visual hallucinations, auditory hallucinations, tactile hallucinations. So there is more data, lot more discussions and clarity. I am going to, for the time being, stop here and once again take us to the summary of this. The summary is, number one, a lot of people. So how many people start getting long COVID? About 8 to 10% of the cases. What we do not know is out of asymptomatic how many, but they do also become long COVID as well. Secondly, 2.7% of the population, that is the data we have from UK. So this is the number of people that may be suffering. And their suffering is not within 1 or 2 days. If they start recovering within 3 months, then usually they recover within 6.5 months. If they do not recover within 3 months, or they do not start recovering, then they can continue to have the problems even beyond 7 months. 91% of the people with long COVID continue to suffer after 7 months. So this is the discussion. Thank you very much. In the coming days now, we'll take individual clusters and organ systems, talk about their pathophysiology, and then talk about the management approaches. Thank you very much for being here, and I would see you again.